right, thank you kindly for the warm introduction. Thank you, judges. Thank you, Elijah Desmond, for hosting this. Thank you, everybody, for coming out. I'm so honored to see everybody here. Let's do a quick show of hands. Who here has an Instagram account? Throw your hands up. Who's got an Instagram account? All right, right on. What were the big ballers on Instagram doing yesterday, Friday? Full Arch Fridays, right? You guys have seen this? Prosthodontists like me posting their big cases. They love the use of that alliteration, Full Arch Friday, right? So we do Full Arch Fridays in our office. That's what I say on social media. In the office, my wife, who's also our practice manager, she calls it 50K Fridays, right? That's a big day. A full mouth case, that's a handsome payout there. And that leads into wine on the weekends, right? When we want to celebrate. So a few weeks ago, we're having a Full Arch Friday in our office, right? And I've got a couple third-year pros residents joining me from Boston. They had a vacation or something like that, and they're out visiting my office, and they want to see how Miles Cohn does a full arch case. They want to see how I do the aesthetics. They want to see how I do the lab work, because I do a lot of my own ceramics, right? They're very interested to see how is this process going to go down. And so I'm going to talk to you guys now a little bit about how this unfolds, okay? We had a young female in our office. We're going to do 28 restorations. This involves veneers, implant crowns, monolithic restorations, right? You name it, we got it. Day starts off like any day starts off. Take the temps off, polish the preps, meticulously try in every single restoration, snap that floss, look at the aesthetics. I have her look in front of our big picture windows. I have her walk under the fluorescent lights, right? Metamerism. I want to make sure that these look good in all conditions. Patient's psyched, she's thrilled, she loves it. Now comes the laboratory work. Now I go back into the lab. It's time to do some chemistry. So what do I do for these restorations that are going to be bonded? I do a lot of hydrofluoric acid etching. Also do phosphoric acid etching. If you're not doing that, talk to me after. Put it through the ultrasonic bath, 91% isopropyl alcohol for 5 minutes. 8 painstaking hours later, we're finally ready to bond and lute these restorations. Okay, now in these days, I book one patient. That's it. We're a high-end boutique practice. I don't do volume. We do really high level for just 1 or 2 patients every day. That's it. So now the residents are watching this. They're taking notes. They're psyched. They're seeing stuff they haven't seen before. Now we get to the mouth. We bond all those restorations painstakingly, one at a time, right? I think the residents are exhausted. They're yawning. Their eyes are getting like big. They're wondering how I'm doing this, right? And I'm just feeding off of the energy. I'm taking photos the whole time, right? If you guys have seen my Instagram, you know I post a lot of photos. I document a lot. I publish in papers, right? I've got to do that. That's a big part of my practice. It's not just the money that I get from the restorations, which, oh, by the way, isn't that much. Even though I say 50K, half of that goes to the lab technicians if you're using a really outstanding ceramist, right? So now we get to the most important part of this entire procedure, checking the occlusion, right? So I have a very unique method that I've adapted over the last decade to check the occlusion, and as a board-certified prosthodontist and certified dental technician, I'm going to share that with you guys today because I think it'll really help you with your patients. So I sit the patient up from the supine into what we call the alert feeding position. All right, that's a real prosthodontic term. Patient's in the alert feeding position, head facing forward. I get some tweezers or cotton forceps, put a thin piece of articulating paper in there, put it between the teeth, and here's my 3-step process. Tap, 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 and I'm done. That's it. I think this news is a little disconcerting to some people, right? Especially people who've been through Coyce, Pankey, Dawson Academy, right? You're all taught a certain way of doing things, and this typically flies in the face of that. And I think the residents that were observing me, I think their jaws hit the floor. They said, but wait, Dr. Cohn, where's the T-scan? Aren't you going to do a T-scan? Why? Throckmorton disproved that years ago. I don't need to do a T-scan. It's expensive and inefficient. Okay, but certainly you had a kinematic face bow, right? No. Why would I do that? Again, it's inefficient, and the literature shows that you can actually do harm to your patients using a face bow incorrectly. But certainly you've used a fully adjustable articulator to work out the occlusion, right? No? Right? When I was in residency and we had to do pantographic tracings, and I mounted that first case of mine on a Dinar D5A. Has anybody ever used one of these? Super fickle, falls apart, right? And then I put the crown in the patient's mouth. I end up grinding on it for 30 minutes. And then I start to question, wait a minute, the triple tray impression I made last week went in much easier. Why did I spend 3 or 4 hours doing all of this stuff? And so these residents are sitting there and they're like, okay, this is a totally different mindset that I need to get around, right? I didn't always have this mindset either. To get to where this started, we have to go back to when I'm now a second-year resident. So I'm at home watching cartoons with my kids on the weekend. Our house is not a democracy, so I get to choose the cartoons, right? I don't even know half of the stuff that my kids are watching today, right? It's insane. So I go back old school, the stuff that I was familiar with, and we're watching Roadrunner, Wile E. Coyote, right? You guys know this, right? Everybody remembers it? What happens all the time? The coyote is desperate to catch the Roadrunner, and he buys from the Acme whatever company the sheer volume of asinine crap to try to catch this Roadrunner. But he never does he? He constructs these elaborate Rube Goldberg machines to try to catch this damn bird, but he can't. And what happens half of the time? He ends up blowing himself up. A boulder falls on him. He gets hurt in the process, right? And something clicked in me when I was watching this, and I said, what if what we're doing is actually harming our patients? What if these Rube Goldberg machines that we're creating is actually doing harm to our patients? So I'm going to go through a few of the things that I started to discover that I was doing in excess that I was able to eliminate from my practice. The very first one, occlusal vertical dimension. Going back to that first patient, right, we're always taught you test the occlusal vertical dimension. You put 28 temps in there, let the patient test it out for a couple months, see how it works. You know what I found in over 3 dozen cases of testing vertical dimension? 0 of them were unable to tolerate the increase in vertical dimension. We don't test vertical dimension on our denture patients, do we? And it's not uncommon for us to raise their vertical by 10 to 12 millimeters. Why would you test it in your fixed patients? You raise the fixed patients 2 to 3 millimeters. That 10 to 12 millimeters, this is the difference between shooting a bullet and throwing it. You don't need to test it. And every board-certified prosthodontist that I've ever asked, how many of your patients are unable to tolerate the increase in vertical? None. They're all able to tolerate it. Speaking of dentures, let's talk about denture occlusion. We were taught in dental school, lingualized occlusion, cross tooth, cross arch, right? That's how I had to set my denture when I took my test to become a CDT. The only test, by the way, that I ever failed. That was an intense test. I give a ton of credit to lab technicians because it's not easy. I set all of my dentures with canine-guided occlusion. The literature supports that it looks better, and it functions better, and it's easier to set. You guys ever heard the term or the phrase, bolus in, balance out, right? So we spend hours meticulously setting these dentures. And then what happens the moment that patient puts a big wad of steak in their mouth? You think that lingualized occlusion means anything anymore? No. The last one, I want to just say to you guys, there's a lot of things that go on in the world of pros that I've also verified with other specialists, ranging from ortho, perio, oral surgery, endodontics. When you start to scratch beneath the surface and really take a look at the literature, you'll find that much of what we do in dentistry is not backed by real data. It's mostly anecdotal. What I've said today will make some people feel livid. What I've said today will make some people feel liberated. Whichever side you fall on will depend on your comfort level with being labeled as an oral health heretic. And I just want you to remember this. The next time that you encounter a situation that you think may be a little over-engineered or complicated, just recall that all of these steps should be so easy that even a prosthodontist can do it. Thank you.